Okay. Good morning. Akwatu Khenti is Director of Community Resources at the City of Toronto's Social Development, Finance and Administration Division. He has since November 2020 been Special Advisor to the City of Toronto's COVID-19 Equity Initiative and Chair of the Black Scientist Task Force on Vaccine Equity. He is an affiliate scientist with the Institute for Mental Health Research at the Center for Addiction and Mental Health, and an assistant professor with the Dalla Lana School of Public Health. He has collaborated with indigenous communities in Hidalgo, Mexico, and Mexico and Lima, Peru, to strengthen mental health in primary health care and adapt Canadian health promotion strategies to their cultural context. He has also taught a wide variety of courses, from international health, human rights, and peace building to global perspectives on the health of women and children. Akwatu is formerly the Assistant Deputy Minister of Ontario's Anti-Racism Directorate, as well as CAMH's Director of Transformative Global Health. He has a PhD in Health Policy and Equity from York University and was appointed as a member of the Council of Canadian Academies expert panel on socioeconomic impacts of science and health misinformation. Dr. Khenti has inspired many local efforts to improve mental health across low-income countries in Latin America and the Caribbean, Sub-Saharan Africa, as well as South Asia, through intensive substance abuse training and management competencies for local health. My friend Akwatu has devoted a lifetime to making life better for marginalized people in all continents. I give you Dr. Akwatu Khenti.
Thank you very much for that wonderful introduction. Hey, this guy sounds like a wonderful guy. And Anthony and I go way back. I mean, we were in university together a few years ago. So it was, I say a few years ago, jokingly, but we've known each other for many decades. And it's, for that reason, as well as many others, it's a privilege for me to be here today. And just sharing my, does everybody see the screen? It's all okay? Thumbs up?
Yeah. All
right. So thank you so much for the opportunity to be here today and to talk about some of the lessons that myself and my colleagues on the Black Scientist Task Force on Vaccine Equity have learned from COVID regarding the vulnerabilities which have made us susceptible to COVID in a way that other communities were not, which led to a death rate from COVID, twice the white rate of death, of mortality. It's very similar to prostate cancer, where we have twice the rate of mortality for our white peers. And so you see it says wellness lessons from the Black syndemic experience. I borrowed that term syndemic from an anthropologist. And what he said was that syndemic is when there's a synergy between the pandemic and the social determinants, so that the pandemic grasps onto vulnerabilities created by poor social determinants of health, but the pandemic also intensifies those very same social determinants, making you even more vulnerable, more likely to get severe illness, and more likely to die. So that's the syndemic, the synergy of determinants and infectious disease that lead to higher rates of mortality and actually amplifies the vulnerability that people of African descent face. Now, I thank you very much for having done the land acknowledgement. I just want to say that, and quoting the words of Justice Murray Sinclair, that we need to build a Canada based on shared future, a future of healing and trust. And it's not happening to the extent that it should, because every day, every week, you see revelations that indicate very clearly colonization is still a tremendous reality across this country. And one of the easiest ways is when people talk about the rule of law and what that means. And you know, the concept of the rule of law, what it means really indicates how outside the rule of law Indigenous people are, and when they experience justice. And a similar thing could be said about people of African descent. Allow me also to do an ancestral acknowledgement. I myself am from Trinidad and Tobago, the descendants of slaves and Indigenous people who have been exterminated from the island of St. Vincent, the Caribs, but also, of course, slave masters, genetics as well. And one of the points that I've been making throughout the past 2 years, and actually for many decades, is that the African people who were brought to the Western Hemisphere from Brazil right up to Canada didn't come empty-handed. They came with skills, resources, knowledge, techniques, technologies. And what's since happened is that as the African was caricatured, even his phenotype or her phenotype became the subject of caricatures, so did the legacies that we brought to the Western Hemisphere, which actually shaped the economic futures of the Western Hemisphere. We brought technologies to America, such as rice cultivation. And I cite that specifically because women brought it. And it's also important to note that when the slaveholders went, or the slave traffickers went to Africa, they were also looking for specific talents, knowledge, and skill sets. They didn't just go looking for everybody. They went looking for specific. And so they deprived Africa of critical resources, which would have led to that continent being a supercontinent in 2022, had the demographic sort of trajectory not been interrupted for 3 centuries. It's very important. And I also like to bring forward the name of one individual, Onesimus, an African, probably from Ghana, because he said he was an Akan speaker. So all probabilities aside, almost certainly from Ghana. And Onesimus was brought to Boston in 1712. And in 1716, between 1716 and 1721, Boston experienced a smallpox epidemic. And the person who owned Onesimus, a minister, noticed that Onesimus, everybody was running around panic. Onesimus was chill, even though, you know, living life as a slave was rough. So what's going on with you? Why are you not scared of smallpox? Onesimus told this guy, his name was Cotton Mather, that he didn't worry about smallpox because when he was a child in Africa, the healer went around the village. He took some pus from the one who was infected with smallpox and stuck everybody and scratched everybody around the village. And they got sick a little bit, but then after a while, they never got smallpox. And it's that revelation from this African Onesimus that introduces the science of vaccination, or what was then called variolation, to North America. That's the first North American recorded discussion of variolation, brought by this African from West Africa. And Cotton Mather would partner with another physician and do actually some first, a rudimentary type of clinical trials to see if it worked. And it worked. And so the Western Hemisphere owes some of its health traditions and health science to African people, but you will never know that from the text. You would never know that from the popular culture. You would never know that from the way we ourselves perceive science. Throughout this past pandemic, one of the key learnings is that science is for Black communities to sort of build the scientific literacy of our community. We don't have it. We need it, especially because we are at the receiving end of so many racial disparities within science where we are not represented in clinical trials. And that also applies to prostate, but it applies to many other things as well. And you'll see, so I sort of signal myself. I'm going to share with you 5 fundamental lessons that we learned during the pandemic. And the reason I say 9 I chose 9 is because in the Caribbean and Latin America, Brazil especially, when someone dies in certain cultures, they have something called 9 nights. Jamaica to Trinidad to Haiti, Dominican Republic, Brazil. And for 9 nights, the person who has experienced the loss, does nothing. They're at home, they're in their home. And people bring food, they bring drink, they bring everything. They bring entertainment. And for 9 nights, you're there, you're receiving people every night, the one who's experienced the loss. And what you do is, what happens is that you go through 9 nights of grieving, celebrating, mourning, but ultimately healing. It's a very healing process that's costless to the society. And I never thought of it as therapy. I always thought of it as something to watch you come into the 9 nights, because you have all these strangers coming. When you have a death in Trinidad, all of a sudden you see like 100 people show up who never know the person who died, but they come for the rum, they come for the food, they come for the entertainment, they come for the laughter. And during COVID, for the first time in recorded history, since we've been in the Western Hemisphere, people of African descent were not allowed to grieve properly, even though we were experiencing disparate mortality, higher rates of death. And those death rates were extremely high in South America, extremely high in Central America. But in those places, race-based data is not collected to the extent that it is in the United States. And of course, the experience in the United States and Canada is very clear-cut. So that's why I chose 9, because I believe that we're still in COVID, and following COVID, we really have to think through, how do we understand the grief that we didn't really process in the African way that we have, the lives that we didn't celebrate in the way that we are accustomed to, that allows us to move on, the mourning that we usually do. And in some places, the mourning, I mean, like, it really is theater, drama. And I know many of you from different cultures probably have the same thing, but people walk up to your door and everything looks normal and as soon as they come through the door, they throw themselves on the ground and they're bawling and they're crying and they're screaming. And you say, boy, that is real theatrics. Yes, you really love Thomas, but it's a healing process. It fosters relief, and not being able to do that, I think, is problematic. And so I think that that our thinkers and our researchers really have to think about measuring where we are with grief, where we are with resolution, because all anecdotal records suggest that our mental health burden increased tremendously during COVID, and the World Health Organization has actually acknowledged and recognized mental health as a huge additional burden on top of the burden that existed prior to COVID that must be addressed in order for the world to move forward. So lesson number 1 is about the huge risk gaps that Black people, Black Canadians of African and Caribbean and European ancestry, because we have a lot of people, Black people who have come here from England and Spain and Portugal, or what have you, and what that did for them during COVID. And there's different types of vulnerabilities, but the health vulnerabilities are the chronic conditions that Black people have with respect to diabetes, hypertension, asthma, high blood pressure, which has been going up over the past 2 decades, especially for women. Just to give you an example, diabetes in Canada, you probably know this already, you probably know the statistics. South Asians have the highest rate of diabetes, followed by Blacks. So the Black rate of diabetes, or the prevalence of diabetes at 12.9% is 6.6 times that of the whites, who have the lowest rates. Similarly, with respect to high blood pressure, in Canada, 30% of Blacks have high blood pressure compared to 21% of whites. And this high blood pressure, of course, as you know, makes us susceptible to strokes, just as diabetes does. So, and COVID was attracted to communicable conditions, especially asthma. And we have a lot of people with multiple conditions. We have a lot of people who actually have hypertension, diabetes, asthma, and are at solid risk. Or also, they're not actually dealing with their chronic conditions well, do not managing their chronic conditions well, which makes them additionally vulnerable. So that was one thing that we saw immediately, which contributed to our higher mortality rates, and for which we actually have to address it systematically to prevent it from leading to our gross death for the next pandemic. There's already mutations of COVID taking place in different parts of the world. Some of them potentially more virulent than the ones that we're dealing with right now, which means that we could actually go back to conditions in wave 1, where we were 9% of the population, but 30% of the severe illness, hospitalization, and death. And of course, this is very relevant for prostate, because when Black men get prostate, or Black people get prostate, they tend to have comorbidities, which makes them at greater risk of full recovery, even though, you know, if you catch it in stage 1, you almost have an 85% chance of full recovery in 5 years. But when you have all these other chronic conditions that you have to manage, it's a huge challenge. So that's lesson number 1. Lesson number 2 is about substance uses. And again, what this lesson number 2 about substance uses also relates to the real need for race-based data to understand how our community is reacting to crisis, and where are the trigger points that we need to really address our prevention and interventions. Because we have huge substance use gaps that's not showing up in data, because we don't have systematic race-based data in health systems that are provincial across the country. People are afraid, or think that we will be afraid of the results if they collect race-based data, which shows the huge disparities, or perhaps no disparities. It'd be great if we had no disparities. One of the areas, just because it's so little known, I could talk about cannabis, alcohol, and tobacco, but I actually want to talk about opioids, because you probably hear a lot about opioid poisoning, opioid deaths taking place across the country. We have a huge problem in Ontario, huge problem in British Columbia, huge problem in the Western provinces. And a lot of Black people think that's a white problem or an Indigenous problem. I have met very few Black people who think opioid poisoning and opioid deaths is a Black problem or a racialized problem, when all the data from the US indicates very clearly that the group that's dying the most from opioids for the past 4 years, Black people, they have the highest mortality. And they have been increasing, their death rates from opioids have been increasing about 44% over the past, since 2020, compared to 22% for whites. And if we had race-based data in opioids in Ontario, I think we would find the same thing. I don't know, I have no idea what it might be like in British Columbia or Saskatchewan or Manitoba, but the states that border Ontario, it's very clear the case that Black people between the ages of 15 to 24 have been experiencing the highest surge in death rates from opioid poisoning over the past 4 years. And some of this opioid poisoning and opioid death was a response to the lockdowns. You know, the way people use drugs and didn't go to clinics where they could have safe use or what have you, or use with friends, also led to people using at home by themselves and dying as a result without medical intervention to save their lives. We also have a wealth gap, and people have been studying this and thinking about this, like Anthony Henry, for the longest while. But that wealth gap actually proved to be so critical during COVID, because Black people disproportionately lost jobs. They were in service industries, frontline professions, and some kept their jobs, but many lost their jobs. Many people who had 2 and 3 jobs lost one of their jobs, because many of our health workers who were precariously employed, especially not the nurses, but the nurses aid, the people who clean the places, who work as PSWs. As PSWs in Ontario, largely Nigerian women and Jamaican women. That's the largest group of women from the Black women involved in PSW work. And suddenly they found they couldn't go from institution to institution, so they experienced a loss of income. And what that loss meant was that people had to use their wealth to cover their expenses, their savings to cover their expenses. And again, we don't have race-based data for everything, as we did for COVID in Ontario, but for our partners in the US, what they found is that 46% of white people were able to use their savings to pay their expenses. Only 30% of Blacks were able to do that. Most Blacks had to borrow from friends to pay their bills during COVID. And as a consequence, many Blacks lost their homes. They weren't able to keep up with their mortgages, missed mortgage payments, lost their homes. And as a result, in Toronto, where I'm fairly familiar with the data, although Blacks account for 9% of the population, we are now 30% of the homeless. 30% of the homeless, 1/3. That's a huge surge because of COVID. And it tells you that wealth has to be taken seriously. And I'm of a social democratic leaning. I'm not a wholehearted capitalist, all in the capitalist model of economics, but without wealth to protect us, without wealth to depend on during times of crisis, we are overexposed and more vulnerable than other communities when things like a pandemic happens and when we actually suffer most from it. The other thing that we learned during the pandemic, which we knew that racism was a social determinant of health. That's been well established through WHO studies, other studies in Europe, etc. What we didn't know was that anti-racism, especially anti-Black racism measures worked and would work to mitigate the risk that Black people experience in health settings. And I could cite you where some efforts to address negligent communication. That's poor communication or communication that's poor because of implicit bias, where the introduction of a greater accountability for that led to communication in primary healthcare being improved, and people felt listened to, and people talked more about what their conditions actually were. I can also tell you that one of the sort of the biggest learnings also was in the area of commercial algorithms. That when you applied an anti-racist lens to some of those neutral commercial algorithms, such as the ones that assign healthcare in America to people with complex health needs, what you find is that Black people are being subjected to or getting less care than they deserve. So anti-racism makes a difference, especially anti-Black racism. It's not just about anti-racism. It's about understanding how anti-Black racism works, because anti-Black racism has had 3 centuries to take root and develop and grow, so that even if you find a cure for disease like for HIV, Black people still die and get HIV in disproportionate rates, even though they don't need to. But because of the vulnerabilities that are built into the social structures of the Western Hemisphere, this is what it is. What are the lessons also during COVID was about digital health support and accurate health information that could be provided through digital means that we had to because of the lockdown. So we had to develop digital resources, rely on digital resources, digital mental health apps. And for the most part, it was very good. But what we also learned was that people who are low income and racialized, and especially Black people, have many handicaps with respect to the use of technology. And that it's not just a question of developing digital health tools, or even making those tools culturally compatible with the needs of communities, because we found, English was a problem, so we had to actually translate it. We actually translated it into Amharic. We translated it into French, into Swahili, into not some West African languages. I think it was Yoruba. But we actually had to support people to gain some digital skills. And that once we did all those steps and followed through, we increased COVID vaccination uptake, because people felt more comfortable registering, going in, doing it, given the support to sort of reduce fears, both of technology and of the system at large. And of course, we have access gaps, which you all know about. And this is the way I explain the access gap. There was a study done by Statistics Canada in 2020, which found that we have first national mental health study survey. And, we, of course, as you would expect, depression, mood and anxiety problems, greater rates of prevalence. But what was very interesting was that 66% of the people who said they didn't have a mental health problem, they were mentally well. 66% said that if there was a Black mental health professional near them, they would go and see that Black mental health professional. So here they're saying they don't have a mental health problem, but that if a Black mental health professional was available, they would go and see the Black mental health professional. I think that need to have a trusted source of information, a trusted person that you could talk to, because you so distrust the medical system, you so distrust, and that distrust isn't groundless distrust. Because that distrust is based on experience. It's not book distrust, it's experiential distrust. And I know fully well the distrust because I know I have a dad. My dad has dementia. He's in an institution. But for the past 4 years, I have to go shepherd him through this emergency room after emergency room. And my dad doesn't look like me. My dad looks like out of West Africa. He's of West African origin, pure African features. And the lack of empathy was shocking. And if I wasn't there to speak up and said, what's going on? We pay taxes. We need, it's our right, not just to have care, but to have quality care. If I wasn't there, he wouldn't have gotten it. And so what happened during COVID, when it's COVID lockdown, you're locked into nobody could go in with you in an emergency room. You are on your own. And this is one of the things, we talked to the community, we said, you don't want to be in an emergency room by yourself. Because when you're in an emergency room, you need your family with you. But during COVID, if you end up in an emergency room, there's nobody there to protect you from racism. Because racism doesn't stop because of COVID. And so we have this access gap, which makes it very important for us to be able to be straight up about what we're experiencing with health professionals that we trust. And that's in COVID, that's in diabetes, that's in various cancers, breast cancer, prostate cancer. We need health professionals in these arenas that are Black. That's just the bottom line. And not having them there, not having them in research, and then one of the critical areas is research, because unlike the COVID vaccines, which has the highest rate of representation of Blacks ever, that's not the case with prostate research. And so how do we do that? How do we build up and scale up Black representation in these areas? That's a challenge. And we've actually started to address it at the University of Toronto, bringing in more postdocs from all over the world, having more medical students that are Black, creating specific space and specific resources to support Black students into medical school, through medical school process. So for the first time, we have more than one. For many years, I taught in public health, 20 years almost. And if I saw one Black student, that was a lot in taking the grad courses that I taught. But for the first time, I have 3 and 4 in my classes, because I teach a class in Black mental health and anti-Black racism in public health. And for the first time, they're there. And that's partly because of the George Floyd moment, but it's also because of the fact that we have people ready, willing, pushing. And when the opportunity arises, they were ready to grasp that opportunity. Of course, I could talk about this all day long, because structural protections are fundamental determinants of post-pandemic community well-being and recovery. And going forward, especially our people who work in conditions where they're exposed to infectious disease, you got to have 10 sick days. 10 sick days is a basic expectation. You can't expect people to take care of themselves if they don't have the sick time. If their kids get sick, they can take care of their kids. And if they get sick, they can stay home and don't go to work and expose themselves to other illnesses that might make them even more sick and make their colleagues sick. What also the data is showing is that Black communities benefited from the universal income supports in a way that they hadn't gotten before. And so one of the things that has become a sort of an advocacy piece for us is basic income, basic universal income, as well as specific cultural interventions in these disease areas where we need specialized approaches, where we need culturally competent approaches to sort of ramp up our statistics. I should also add that there's an emerging literature that indicates that when disparities are eliminated, our recovery rates from prostate surge, and we actually achieve parity with the right population. And that's been the case with a recent study of 300,000 patients where race was found to be irrelevant because the care that everybody received was high quality care. So high quality care mattered. Similarly, with respect to COVID and COVID vaccines, we were able to achieve parity in Toronto in some of the highest needs areas with COVID vaccines, despite everything. So because of the trust-based intervention approach with ambassadors and Black people delivering the information. So we know that we can have parity on these issues if we address the fundamental determinants and if we provide culturally relevant messaging. Equity matters. Equity in healthcare matters. And I'm just going to end very quickly because I know I'm all the time. You know, the silver lining of the cloud during COVID was the fact that we were able to spend more quality time with our children. And that's so important. Unfortunately, many people were not able to do that. Many communities who are strapped with socioeconomic needs, they have to get out there and work. Parents have to work 2 jobs no matter what. No matter if their kids at home, they can't really stay home and homeschool. So a lot of kids didn't fare too well during the pandemic on the school lockdowns. And some data is already showing projected increases in lower rates of graduation, lower life expectancy in the US because of shutdowns. But I actually believe there might be a silver lining, especially for Black boys, because going to school as a Black child is a challenging condition anyway, boys and girls, but it's particularly challenging for males because from daycare, believe it or not, from daycare, by the way, we experience disproportionate suspensions from daycare. And you would say, well, how is that possible? How could you be suspended from daycare and have a racialized rate of suspension from daycare? How's that possible? Well, it was possible and happening until Ontario made it illegal to suspend kids from daycare from elementary school years. I think Black children and Black youth face multiple microaggressions through their lived educational experiences from elementary school, as expressed in expulsion and suspension rates. Just to give you an example, we probably have similar rates in other cities. 9% of the population in 2016, 2017, 36% of the suspensions in the Toronto District School Board. That's 4 times the rate. And it's 36%, but that 36%, 80% is male. 80% is male. And being a young Black male in elementary school, grade 1, 2, and 3, especially where your nonverbal skills, you're nonverbal, in terms of experiencing microaggressions and being able to articulate to your parents and for yourself what you experience, I believe that's where our biological weathering begins. And the biological weathering is the physiological aging of your body, and which makes you more susceptible to these prostate risks when you're an adult. It's what McEwen and company developed as the concept of allostatic load, including such factors as cortisol level, sympathetic nerve activity, blood pressure reactivity, to represent the cumulative wear and tear on the body's systems of experiencing racism from the cradle to the grave. And I don't know if many of you who come from the Caribbean, I know the Caribbean very well. I know Nigeria a little bit and Tanzania a little bit and Sudan a little bit, but I know the Caribbean very well. And in the Caribbean, adolescence involve risk-taking, going in other people's backyard, stealing their mango, stealing their fruit. You would dare to do that, and if you didn't do it, people say, what are you? So, but the shift in the 80s and the 90s was to criminalize activities that used to be normal adolescent male activities. And that criminalization was deliberate in North America, but it influenced and engendered similar cultural shifts across the world. And I believe that although we don't have data to back it up, what we have is anecdotes to back it up, that our own biological vulnerability has been induced by extra stress due to systemic racism, and not just racial harassment, which is human rights violation. So you don't get, remember, we don't get the name calling we used to get, the physical attacks we used to get. That's not, actually that's now almost exceptional. But what you get constantly is the invalidations. You put up your hand, they don't ask you a question. You give an answer, they don't give you support. They don't say, wow, what a great answer that was. So, you don't get that backup, that enthusiastic response to your intelligence and your beauty, which turns many off to the education system and to their own personal growth. And finally, I like to end with laughing, because as you know, humor is something that mitigates some of the risk, the pain, the discomfort of dealing with prostate cancer and any cancer. And our culture, properly understood and harnessed, is a source of coping strengths and healing, especially the humor. If I had more time, I'd talk about some of the evidence that indicates very clearly how humor boosts the immune system and improves the overall health of patients with cancer. But belly laughing is something we understand. And we have in the Caribbean and Central America, liming cultures, liming cultures, the art of doing nothing. And it's particularly relevant for people who are low and middle income, liming culture, liming. And liming isn't just about hanging out. Liming is about telling jokes and laughing. And it's the most cost-effective resilience building in the world, liming. And in those limings are a repository of many African wisdoms and proverbs, and that's also articulated in song. And I want to leave you with two particular proverbs from the Caribbean that I've used in my conversations with communities, because I've been, over the past year and a half, I've been in about 100 town halls across Toronto with various communities. And from Trinidad, we have a saying, laugh and cry does live in the same house. Laugh and cry, you know it, you heard it, maybe some of you. Laugh and cry does live in the same house. That concept, laugh and cry does live in the same house, is akin to a Buddhist concept of the mind is its own place and can make a heaven of hell or a hell of heaven. Shakespeare said the same thing. The mind can make a heaven of hell or a hell of heaven. We say laugh and cry does live in the same house. That means you have a choice. You can choose to laugh at your situation or cry. You could cry. If I start to cry, you'll cry all day long. That's why it's better to laugh. Because laughter reduces the pain. Laughter boosts your immune system. And during the COVID, you need to boost your immune system. The other one, which comes from Nigeria, I got it when I was in a place called Enugu, Nigeria, a couple of years ago. And I used it ever since. They say it doesn't matter, these people in Enugu taught me, how nice a coffin looks. That coffin could be made out of gold. It could have silk sheets, the most expensive pillow in the world, lined with all kind of ornaments. $1 billion coffin, you can have $1 billion coffin, and no one is incentivized to get to the coffin sooner. No one. And so that is something that we don't run to. It's something we run from. So when you don't get vaccinated, you don't exercise precautionary health care, take precautionary health care measures. That's actually inconsistent with what your culture tells you to do. And you know, we had a few years ago, I actually experienced some songs where people were talking about the prostate test, calypsos, where they were talking about prostate test, and it was all about machismo and having a man put his hand up your bum and all kind of thing. That was what the calypsos were about. But the culture, there are elements within the culture that informs you very well how to deal with health because you don't want to die. Thank you very much.
Thank you, Akwatu. That was really, really good presentation. Thank you very much. The one thing I'd like to point out, you mentioned about not seeing Black researchers, Black medical people, and when you go to the clinics. Just want to point out that the Walnut Foundation has just invested in an endowment at the University of Toronto Faculty of Medicine, which would go towards funding an award for Black medical students entering the Temerity Faculty of Medicine at the University of Toronto. And that has just started this year. We've put a seed of $26,000 down, and every year we're going to add to that, so that we want to see more Black medical professionals in the university as well. So I just wanted to point that out. The Walnut Foundation has started on that as well.
Excellent. Thank you so much.
Thank you very much. I'd really appreciate that.